Welcome back, everyone. In today's explainer, we're going to literally sketch out something truly fascinating: the complex electrical grid of the human lower limb. If you picture this like an animated sketch, we're going to visually trace the major motor and sensory nerves right from their origins in the spine all the way down to the tips of your toes. But hey, we aren't just here to memorize anatomy today. We're going to look at this like master electricians troubleshooting a circuit. By the end of this, you'll understand exactly how specific nerve lesions present in the clinic, complete with real-world scenarios and a few really handy visual mnemonics to lock this knowledge in for good. To get us started, I want you to consider a bit of a clinical mystery. Imagine a patient comes in. They broke a bone a few weeks ago, right? And they had a simple, standard plaster cast put on their lower leg. But when that cast comes off, they suddenly find it completely impossible to lift their toes off the floor. They've got what we call a foot drop. So why on earth would a cast cause that? Keep that question in the back of your mind, because as we trace the wiring of the leg, the answer is going to become blindingly obvious. Okay, let's dive into this roadmap. We're moving proximally to distally today. We'll hit the master control plexuses, the anterior thigh and hip, the gluteal and sciatic region, the lower leg and foot, and finally, we'll wrap up with cutaneous sensory mapping. Let's jump in. Starting off with Section 1, the master control plexuses, basically the power stations of the lower limb. When looking at our power stations, we essentially have two main origin points. First, there's the lumbar plexus, which is formed from the ventral rami of spinal nerves L1 through L4. This primarily supplies the anterior and medial thigh. Then you've got the sacral plexus joining with the lower lumbar nerves to form the lumbosacral trunk, covering spinal nerves L4 all the way down to S4. This absolute powerhouse supplies the gluteal region, the posterior thigh, and virtually all of the leg and foot below the knee. Moving right along to Section 2, the anterior thigh and hip. Let's wire up the front of the leg. Now, what's really interesting here is the path of the largest nerve of the lumbar plexus, the femoral nerve. Coming off L2 to L4, it routes deep right to the midpoint of the inguinal ligament. It's this massive, thick nerve bundle, perfectly positioned to just drop right into the anterior thigh to power your massive quadriceps muscles. In the front of the thigh, it's essentially a tale of two nerves. The femoral nerve is your primary hip flexor and knee extensor. Think of the motion of kicking a soccer ball. That's all femoral. But right next door, exiting through the obturator foramen, is the obturator nerve. This one is the master of the medial thigh, controlling your adductor muscles. So if you're squeezing your knees together, it's your obturator nerve doing the heavy lifting. So how do we actually test the femoral nerve in a patient? Well, we can use the reverse Lasagui test. With a patient lying prone, you flex their knee and hyperextend the hip. This physically stretches the femoral nerve. If there's a lesion or some kind of compression, this stretch will trigger a sharp pain. We also check the patellar tendon reflex with a simple tap of a reflex hammer. The L2 to L4 reflex arc directly relies on a healthy femoral nerve to contract the quadriceps. And this brings us to a really critical clinical distinction. Sometimes a patient presents with what looks like femoral neuropathy, weakness in the thigh. But what if they also have a foot drop where they literally can't lift their toes? That changes the whole game. As our sources point out, the presence of foot drop indicates the patient doesn't have a true femoral neuropathy, but rather a lumbosacral plexopathy. The damage has to be higher up, in the lumbosacral plexus itself, a condition sometimes seen after particularly difficult obstetric delivery. It's a perfect example of why mapping the entire leg really matters. All right, Section 3, the gluteal and sciatic. Time to power the posterior. Before we hit the leg itself, we have to look at the gluteal nerves. A superior gluteal nerve deficit essentially paralyzes the hip abductors. That's the gluteus medius and minimus. This gives you a positive Trendelenburg sign, where the patient's pelvis actually drops on the unsupported side when they walk, creating this very distinct waddling gait. Contrast that with the inferior gluteal nerve, which powers the massive gluteus maximus. If that one is injured, walking on flat ground might actually be fine, but the patient will have immense difficulty climbing stairs or standing up from a chair, because they've lost their primary hip extensor. Moving down the posterior thigh, we meet the absolute king of all nerves, the sciatic nerve. This is literally the largest nerve in the human body. Originating from L4 to S3, it travels down the back of the thigh, providing motor power to the hamstrings for knee flexion. But, as you'll see, this massive cable doesn't stay a single nerve forever. And this brilliantly illustrates the split. Just before reaching the back of the knee, the popliteal fossa, the sciatic nerve divides into two primary branches. The tibial nerve continues straight down the posterior leg, handling plantar flexion, which is pointing your toes down. Meanwhile, the common peroneal nerve swings right around to the front and side of the leg, handling dorsiflexion and eversion, which is lifting your toes up and out. Which brings us to section 4, the lower leg and foot. Let's follow these branches below the knee. Remember our hook question from the very beginning? Why would a tight cast cause a foot drop? Well, here's your answer. As the common peroneal nerve wraps around the neck of the fibula bone, it runs incredibly superficial, right under the skin. That makes it extremely vulnerable to direct trauma or sustained pressure. So a tight plaster cast right below the knee literally crushes the nerve against the bone, causing a neuropraxia that completely knocks out the ability to lift the toes. Let's mentally sketch out another scenario from our sources. A 27-year-old woman develops numbness and a steppage gait. That's when a patient artificially lifts their knees super high to keep their dragging toes from catching on the floor. And this happens after a delivery in obstetric stirrups. Why? Because the hard metal stirrups compress the lateral side of her knee for hours, injuring that exact same super vulnerable common peroneal nerve. Now, the common peroneal actually splits again into deep and superficial branches. We've got a great pick mnemonic here. Just picture the letters PED, peroneal, everts, and dorsiflexes. The superficial branch controls eversion, turning the foot outward. The deep branch controls dorsiflexion, lifting the foot up. If you lose the deep branch, you get that classic foot drop, and you lose sensation specifically in the very first web space between your big toe and second toe. If you lose the superficial branch, you can't evert your ankle, and you lose sensation over the broad top or dorsum of the foot. On the flip side, we have the tibial nerve in the back of the leg. The visual mnemonic for this one is TIP, T-I-P, tibial, inverts, and plantar flexes. A massive trauma, like a posterior knee dislocation, can severely damage this nerve. If that happens, step by step, the patient loses their gastrocnemius cilius complex, meaning they completely lose ankle plantar flexion. They can no longer stand on their tiptoes, they can't push off when walking, and they lose sensation over the entire sole of their foot. Finally, section 5, cutaneous sensory mapping. Let's map out the skin. So the crucial point here is that sensory loss is essentially a treasure map for doctors. By poking different parts of the foot, we know exactly which wire is cut higher up. Lateral edge of the foot, that's the sural nerve. Medial edge, saphenous. Top of the foot, superficial peroneal. That tiny space between the first two toes, deep peroneal. And the sole of the foot, tibial branches. I really want to highlight the saphenous nerve in particular. This is the absolute longest sensory branch of the femoral nerve. It takes an incredible journey, passing through the adductor canal on the thigh, running all the way down the inside of your calf, and finally terminating right at the medial side of the big toe. And remember, it provides zero motor function. It is a purely sensory wire. Another purely sensory issue you should visualize is meralgia paresthetica. This is the compression of the lateral femoral cutaneous nerve, or LFCN. Because it passes right under the inguinal ligament, things like tight clothing, heavy tool belts, or even pregnancy can pinch it. The result? Localized numbness and a really uncomfortable tingling, burning sensation over the anterolateral thigh. Okay, let's combine everything we've sketched out today. If a patient suffers a severe pelvic fracture that crushes both the obturator and femoral nerves at the same time, what happens? Well, they'd lose hip flexion and knee extension, that's the femoral. They'd lose the ability to squeeze their thighs together, that's the obturator. And sensorially, they'd be entirely numb over the front and inside of their thigh and all the way down the inside of their calf to their big toe, thanks to the loss of that saphenous branch. Anatomy really is a beautifully logical puzzle, isn't it? Here's a final thought to leave you with. If the wiring of just your lower limb is this incredibly intricate and vulnerable, imagine the staggering complexity of the cranial nerves you're using right this second just to watch and understand this explainer. If this breakdown helped you map out this logical puzzle and you liked our mnemonics, please do us a huge favor. Like this explainer, share it with your study groups or colleagues, and absolutely be sure to subscribe to the channel so you never miss our deep dives into the fascinating machinery of the human body. Keep learning, and I'll catch you in the next one.